Right, bang on 4 o'clock. I've been watching the clock like evil eyes. Welcome everybody, good afternoon. Welcome to our LTV ethical framework. I'm sure you've seen the slides and everybody I can see is doing this already. So make sure your microphones are muted, your cameras are off. Have a think about any questions that you might like to ask, because there will be opportunities at the end of each session, but please pop them down the right-hand side in the chat. We're really excited to be holding this day and really glad that you've joined us. Big thanks to Aerogen, who are actually sponsoring this for us. So let's have a little look at the agenda. I won't go through it because each presenter will present their own sections, but just to say this has been 2 years of work already, so there's a lot to get through, but we're really keen to hear your views, so please use the opportunity to engage. That's really important. So from my perspective, just to give you a little bit of background, I'll introduce myself, I suppose. So my name's Brennan. I'm a children's critical care nurse, so used to looking after children on LTV, and then I deserted the ship and joined NHS England about 2 years ago now. And I wanted to just give you a little bit of context to the work that we're doing from a broader perspective, and just to think about this nationally in terms of the recognition now in the long-term plan of the need for children who've got complex needs, long-term conditions, often life-limiting conditions in our long-term plan. And actually that's a huge thing. We've now got a whole chapter relating to children and a recognition that this is something that needs to be addressed and that children are a priority. If you go back to 2016, there was a national review into children's critical care and surgery. And what came out of that, apart from lots of things about how we improve the service, was a recognition again that it's children with complex needs. They're 10% of the children, but actually occupying 50%, half of the bed days in critical care. And we know that's not an appropriate environment. And we know there's an urgent need for children to be cared for more appropriately closer to home. The third thing is about our developing landscape. And what we mean by that is healthcare, social care, mental health care, physical care provision. And actually what's improving, hopefully going forward, is a join up of care. So you may be familiar with the development of integrated is a hard word, care systems. We're going to have 5 of those in London. They'll be replicated all across the country. And the aim of this is to look at care across the whole system, so community right through to tertiary care. And we know that's really important for our children, that we have a joined up pathway and that we match the provision of care, whether it's at an acute care level or children are being cared for at home. And then finally from me, just a little bit about setting up the actual, next one, ethical framework and the focus group. And then Joe Brierley is going to talk to you in more detail about this in a second from an ethical perspective. But where this group came from is from a number of routes. I've already mentioned about the national review and a national focus on long-term ventilation. We also have 2 networks in London, South Thames and North Thames Paediatric networks. And there were lots of workshops and discussions, and this was about critical care initially, but LTV, long-term ventilation and the needs of those children kept coming up as, please, we need to do something about this. There are real challenges here. And I'm sure you as an audience are already familiar with what those challenges are. And actually then Joe Brierley, consultant at Great Ormond Street, contacted us at NHS England and just basically said, look, how do we get our heads together on this? How do we make a difference and how do we make improvements that are needed? So we started off by pulling together some key stakeholders and just getting our heads together. And you can see that that was multi-professional in nature. Also with representatives from the acute side, community hospitals and a parent representative as well. I won't go into any more details, but that's just to give you the background. You can see the aim there below, but I'll hand over to Joe, who will basically go into more details about the full background to this.
Thanks very much, Kathy. Hopefully I'm there for everybody. So my name is Joe Bryan. I'm an intensive care consultant over at Great Ormond Street, and also lead on bioethics in the hospital. So I guess part of this started when Miriam Fine-Goldman, who's now since become a consultant at the Evelina in the ICU, Sam Ray and myself started to look at long-term ventilation really from an ICU perspective, trying to work out how decisions were made. And you can see there's a graph there which is kind of apocryphal from Colin Wallace's original data, showing an exponential rise in the number of children who are receiving long-term ventilation. And you can add NIV as well as tracheostomy, long-term ventilation together to that. And it became clear when we went and we talked to the national LTV meeting, had a really interesting meeting there, 2015, but very different decisions were being made about the same clinical situation in different parts of the country. And in terms of ethics, that equitable decision making seemed straight away a very strange thing to us. And there really wasn't a system for decision making, different access. And of course, we're very used to different aspects of community provision for families, but this is probably one of the starkest areas I've experienced. Families having hugely different experiences who simply have different London postcodes based on their provision they receive with LTV. And having published that, we then looked at maybe trying to get something that might help people with the ethical decision making here, bringing quite a few colleagues from the Brompton and palliative care backgrounds in to try and think about this, because I think it's very important at the outset to say that for children who are dependent on ventilation, if they do not receive it, then their deaths are the other side to this. So the question is about deciding whether continuing long-term organ support at home is the right thing for a child, deciding together with the child, if possible, and their family. Next slide, please. So most of you will have seen this, the Royal College guidance on decision making. It's not really guidance, more of a framework from 2015, which has recently been kind of agreed that nothing had changed since that time. And it really is thinking about how we make decisions. I commend you all to go and have a look at it. I'm slightly biased because I'm one of the authors, but it has a lot of the background ethics into decisions about limiting life-saving treatment. But we didn't feel there was enough in here specific to LTV and felt there needs to be separate considerations. So one of the reasons we pushed to develop the process we're going to talk to you about today is we felt there were aspects of decisions around long-term ventilation that weren't quite featured, but many of the background ethical and legal parts of this world are covered quite well in this document. Next slide. So I'm going to go through the background of paediatrics and what's changed since, I guess, 20 years ago. Survival rates are hugely better. Many children survive, but we are doing more stuff to children, both inside the ICU and outside, to try and save their lives, to try and treat them with various diseases, much more ECMO, Berlin heart, transplants, organ bone marrow transplants, and chemotherapy far more aggressive than previously. Many children doing very well, CAR T-cell, gene therapy. These are all things that 20 years ago were only really dreamed about. But for our area, long-term ventilation in those days used to be provided for children who were going to grow out of their underlying disease. So children who were born premature with lungs that people thought would mature to get them off the ventilator. Occasionally there was the odd child who had a spinal cord injury who might end up on long-term ventilation. But actually much more long-term ventilation is happening for many different conditions. Some children who would previously be labelled as under a palliative care flag, if that's a reasonable thing to say, are now having organ support at home and having a really good period and sometimes living for many years. And the question there is, how are we going to keep up with these changes in terms of the ethical standards and decision making? Into that, there are children having time-limited trials of treatment, children having new treatment that didn't exist 5 years ago, thinking particularly about new treatments for SMA, which are amazingly successful, but are not reversing severe lung disease or neuromuscular weakness that gets children on a ventilator, but might prevent further worsening in children who've been quite badly affected. And then many, many palliative therapies for children with complex neurodisability, Nissen spinal fusion, and VP shunts. This is just to give you the background of paediatrics and real changes. Next slide, please. Next slide, please. I don't have control, thanks. This is probably the best data we have from the ICU world and tells you that on the same physiology and disease processes, different decisions are being made. And we can talk about where that comes from, society, medical practice. This is data from Melbourne showing that 84% survival in 2000s has turned into 90-odd%, as I said, in the 2010s. But many children with complex disabilities, long-term organ dysfunction, are both coming out of, but also going into PICU. Children with PN, children who are going to live on technological dependence in their bedrooms. And this has hugely changed. As Kathy said, many children or a small number of children occupy a large amount of PICU work at the moment. Next slide, please. The other thing is this group of children with life-limiting conditions, this is old data now, but are not spread equally across our society. There are a large preponderance of these sorts of problems in children who come from poor socioeconomic groups, less financially able to spend lots of money on things, and also from ethnic groups where access to healthcare is a particular challenge. And that combination of sometimes poverty, but poor socioeconomic circumstances, and the ethnic deprivation as well, is a real challenge. And it means this group of children, we have not developed systems well enough that help their families optimally. And there's plenty of information about that in the 10-year PICANET review that was done a few years back, but really something we all need to develop much better systems for. Next, please. Next slide, please. And then there are great successes in medicine to triumph and herald. Prematurity, amazing success. The number of children being born at ever earlier gestational ages and doing very well has increased hugely. But the proportion, the percentage, if you like, of children who are having complex problems after premature birth has not changed. So the children who have complex disability, neurodisability, or bad lung function, or short gut syndrome after being born premature is still there, with many more survivors. There are many more children with chronic impairment. And the same story is seen in one of the other major successes, which is cardiac operations for children with congenital heart disease. Amazing success stories. Just a small proportion, but a significant group who have long-term health problems. Next slide, please. So there you can see Kathy Brennan when she was working for a living. I put rather flippantly, technology-dependent children on every street. I think we have to be humble enough to realize that the parents of the children we care for are doing an amazing job at home, often running stuff that was entirely in the ICUs only 20 years ago. I mean, home parental nutrition is now a very standard treatment. Home ventilation, but also renal replacement therapy, some children coming in, some having stuff at home, and more recently, children going home with ventricular assist devices in their bedroom. It's astonishing stuff. But the other side to this is, and I'll use one case to talk about this. Last year, we were referred a child for palliative home long-term ventilation and parental nutrition who had no home. The social interaction, the burden on siblings, the burdens on families are extremely high and very poorly looked through. Next slide, please. So ethical issues in LTV, to finish off, deciding who should be offered home mechanical ventilation and on what basis, respect for the parent and family wishes and the patient wishes, if that's possible to ascertain. But also the decisions about the clinical team, autonomy, paternalism, not the right words really, but having the clinical team involved in decisions and supporting them is very important. Quality of life and dignity, equal access to home mechanical ventilation are crucial. LTV, children's ongoing health issues, though, are a massive thing. As the number increases, many of these children will have increasing need for hospitals, ICU over winter. And then the other question that's not been considered very well is when you decide to stop long-term ventilation. It is, I mean, futility is a very bad word, and I don't tend to use it very much. I put it there to wake you all up at this stage. But the disease progresses. At what stage does it mean that the child shouldn't be supported on ventilation? Or do you carry on that forever until the child cannot be oxygenated anymore? What about burnout in the carers? That's a serious problem. And the other thing is these time-limited trials of treatment. How can we be clear about when failure to improve means we shouldn't be carrying on long-term ventilation? Next slide, please. The impact LTV has on the child is key, on the parents, the siblings, other family members, healthcare services, and resource allocation, and trying to anticipate what that will mean before you decide to embark on this process is really important, and making sure the adequate provisions are provided for the family. The other aspects are very important as well. I'm very guilty here in being, suggesting that, is there a dump on the ward, quick free an ICU bed, send the kid to the community, try and get the child through our services, because one of the problems, we all have pressure on what we do, and we need to really push to what I've included at the bottom there from the paper. LTV is a big decision and should be made after a thought through best interest meeting with all relevant groups, including all the allied health professionals, all the community teams, the commissioners if necessary in terms of funding, but certainly all the people who will deliver care to that child. And I don't think we've necessarily been that good at involving teams early enough in the decision making. Next slide, please. And again, just to reiterate the same thing, early 2000s, we really started LTV, and I think Richard might define it better than I am. I'm leaving it deliberately open at the moment. But it was really for children who grow out of chronic lung disease and the odd high spine injury. 2019 or 18, when we started this process, it is much more a destination therapy, an end decision that you will have LTV and that is your life from now on for many children. A death deferment to buy time for other treatment for various conditions there. So it's a very complex area that needs to be thought through. Next. I'll finish with a quote from Ben Wilfon, one of my ethical heroes, although I don't agree in everything he says. But if you look on the left, we worry about money sometimes, don't we, and all the dreadful situation. And should we be spending all this money on children with complex disabilities? And how do you think about it? And Ben puts a lovely quote together there that society progresses by how it treats its weakness. And I would argue the people on the left, the children, the guy at the bottom right is someone who's benefited from a very, very expensive spinal cord regeneration program. And on the right, I always put a bit of a nuclear warhead there. If you want to decide what our society spends its money on, I would argue that children with complex needs and their families should be right at the top. And maybe we shouldn't ever talk about funding until we, ended up where we really have to push for this. It's a disgrace that we're not spending more in this area. That might be a bit of politics, and I should probably carry on and move on. Well, I'll tell you the last slide was Atul Gawande's quote about cheating death just to prevent death happening is not the right thing for our patients. We have to think about trying to treat them as human beings, and that's kind of where that was going. That we don't spend enough money in this area, but also there will be times when LTV is not the right decision. We might have parents pushing for something that we don't think is right for the child. We might have teams thinking that. The converse is also true. We sometimes have children where we think they benefit from LTV, but the family circumstances or sometimes other colleagues don't think that's the right thing. So it's all about this complex interplay, trying to get people to work together to get to the child's best interests. And I think Richard's next is going to explain the work we've done to try and establish a system. That was called a setup, Richard, by the way.
Good. So I'm Richard Chavasse. I'm a respiratory paediatrician at St George's Hospital, South West London, and have a cohort of long-term ventilated children under my care. And I've been involved with this group for the last sort of 24 months. And I think that, just to say, a lot of people have been involved in this from the start. There are a smaller group of people who've done an awful lot of work towards this. I won't name names so as not to offend anyone that I've missed out, but I think there's been a lot of hard work that have gone into this. And to say that, as Cathy sort of introduced, we started this with identifying a lot of different stakeholders. They were set up at different meetings, and then we gathered together the existing frameworks that people were using for decision-making processes and started to develop a consensus of how we could merge those together, so that there is the equity of care and decision-making and thought processes that Jay so eloquently put together. So next slide, please. And what we found, having started off looking at the ethical framework, was the need to sort of tie that into a sort of a newer operational framework. And this slide is the summation of all of our decisions that sort of tie this all together. And so starting off at the left-hand side of the screen, we've got the child who is either ventilated and in a PICU or an ICU and unable to wean off treatment, which is perhaps one of the more common ways that a child ends up in this situation. but also a child who's not currently ventilated, who's got a diagnosis that is likely to require the instigation of long-term ventilation in the not too distant future. And once those children have been identified, that's where the process starts, where the local LTV team as such needs to be informed, data needs to be started to be collated, and we're sort of developing pro formas to do that. And then the setup of the decision-making, discussion, MDT, clinical best interest meetings to help inform the decision around that. And that means involving not just the ICU or the NICU teams, but the respiratory team, palliative care, a consultant within the speciality, psychosocial services, people from the community, the local DGHs, and clearly as well as the family as the very important people. I'll come back to the operational framework just to sort of talk about the other arms to that, but just going on through to the next slide, looking at the sort of ethical side of things. So Joe mentioned this, who are we thinking about in this situation? And I think we've kind of, to begin with, we've stuck to the children who are most likely to or not survive without the support, so children who need to have LTV via a tracheostomy, and those children who need complex NIV for a lot of the day. So we've come up with more than 16 hours a day. There are some clearly who may need it for a little bit less than that, who may progress to that over a period of time. So there has to be some freedom of discretion around that, but I think we wanted to start off with the most difficult cohort to begin with. And then secondly, there is this the reason for LTV, and here again we come with this dichotomy of children who we hope are going to have time-limited care or a bridge to recovery, and that may be spontaneous recovery with the chronic lung disease of prematurity, or those whose disease may improve with a treatment or the use of an innovative or experimental treatment that may or may not work over a period of time, compared to those children who have a problem that there's no expected chance of recovery, and are then going to be on respiratory support lifelong. And clearly children in that Group B, the time-limited bridge therapy, may transform into Group A over a period of time, and that hence needs a cycle of re-evaluation and re-looking at the ethical issues around that as time goes by. Next slide, please. And then the key things that we feel have to come into the decision-making, the planning for these children, and looking at the ethical side, is looking around the family. As one thing, the parents need to know what they're letting themselves in for, warts and all. Obviously what support they may get through commissioning, through care packages, and what they won't get, and how that's going to impact on their life and their livelihood, other children, relatives, work, and so on and so forth. Housing is one of the other major issues. And ideally, it shouldn't matter where you live as to what sort of care package you're going to be allocated for the same diagnosis, and that's certainly something that we still need to iron out across London and the South East and nationwide. The next step is, or the next consideration is, there has to be a commitment to review that these decisions aren't a one-stop shop, a point in time. As we've already sort of intimated, children will or may change over time, and Group B becomes Group A. Other clinical change or interventions may become needed, and so we have to go through a process of an annual review, which includes all of these, not just how you're doing and can we adjust the ventilator, but looking at the ethical issues, exploration of how the progress is going, what the experiences are, the psychosocial well-being of the families, and whether it's still the right thing for the children over time. And clearly, as the child gets older, you need to start thinking of transition if and when that's appropriate. Next slide. And then we think it's important that families have the chance to hear from somebody who's been through this process, or people who've been through this process, giving them an unbiased review of what it's actually like. And clearly there are families who've had better experiences and others who've had worse, and so we need to think of ways that we can do that in an unbiased sort of way, and whether that's going to be video or web-based interviews with families, or something face-to-face in non-COVID times. But I think solutions need to be found around that, so that families really do get to feel what this all means and what this is going to be like. And as part of our decision making, we also have to explore all of the other alternatives, and in that we're looking predominantly down the non-treatment route, or palliative care, and that should be fully explored. And for many children there should be parallel planning with palliative care for the longer term, and so clearly an important part in getting those teams involved at an early stage for some or many of those children. Obviously, safeguarding issues are something that comes up time and time again, and these kids are often at risk due to the stresses and strains of being under long-term ventilation. But there are issues prior to the decision as well, and those need to be explored and identified and sorted where possible, although in itself it probably doesn't preclude to starting LTV. And the overarching thing, of course, is that all of these decisions have to be made in the best interest. We need to explore that for the child and make sure that it is the right decision, the best decision that can be made at that particular point in time. Next slide. So going on through the operational framework, in the centre box, the blue box in the middle, is the MDT clinical best interest meetings, considering the ethical framework, discussing the situation with the parents and all of the other professionals that need to be taken into that. And that may be an iterative meeting that needs to take place on more than one occasion, several occasions, to make sure that those decisions are made and explored. And we may come out with two broad responses. One is that there's agreement between the parents and the clinical team that a decision can be made, and that decision can be either to continue with or instigate long-term ventilation, or maybe going down the end-of-life holistic support for the child instead. Or alternatively, there's a situation, that the complex situations that we found ourselves in recently, where parents and teams are not in agreement, and there still has to be some additional support to make the right decision. So next slide. So in the next, so in the situation where there's clear agreement that the right decision can be made, a chronic lung disease of prematurity who's got a good chance of recovery over a period of time, the right decision is going to be to support that child for the time it takes. We should be still informing our local ethics groups about the decision, to make sure that we know that there's still a complex situation, and these situations may need to be reviewed, and data collected and stored along those sorts of lines. We're then going to try and progress towards an informed consent, which Ruchi is going to present a little bit later on, and then we go through the discharge planning to get the child home safely as quickly as possible, followed up by obviously clinics to monitor and progress treatment, and the annual review to explore the issues that we've already gone through. In the situation where there's disagreement between the family and the clinicians, or between clinicians sometimes, there we should be firstly using the local ethics meetings to discuss the intricacies of the situation, to review those decisions, and to maybe come up with further recommendations. We know that not all hospitals in London have a suitable ethics committee for that, but where possible, that's the first port of call. We may need to involve second opinions from other trusts, independent, to support the family and to support ourselves, and then potentially go through mediation with the family to find out the reasons that the barriers towards making that consensus decision. If that's still not getting to a situation, we're now proposing a regional bioethics group, which is a further ethical group that will review the situation. Again, ties in expertise from the region to give extra support to clinicians and to families to make sure that we're following the same sort of pathway, and we'll just discuss that in the next slide. And then potentially, and what we're trying to avoid where possible is the bottom line, the legal opinion. My last slide. So this is the Pan-London Bioethical Support Group, which one slide is never going to give all of the information. It's not a replacement for local ethics groups, and so again, where possible in the house, discussions should take place. With the group that again Joe is really king of setting up, is the membership will come from ethical services from around the region, from other paediatric centres, with people with paediatric bioethical expertise, faith group representations, legal expertise, and also lay or other parent, experienced parents with LTV, so that there's a broad base, a broad church to make sure that the parents are getting the support. The group is likely to meet on I think a quarterly basis, but is able to have other sessions on site if needs be in between times, maybe not the full group but smaller groups for advice along the way. And the process, and the whole of this process does need to be audited so that we know that it's making a difference, it's helping us through, whether refinements need to be made. And Joe's also very keen that the bioethics support group has a strong educational component, so that there may be, offline sessions where intricate details can be discussed, but there ought to be learning from each individual case. And my understanding, and Joe can correct me, but I think we've got funding identified for the first 3 years from Great Ormond Street towards this sort of aim. So hopefully that gives a summary of how we've got to where we hope to go, and I'm really happy to take any questions if there are any. Perhaps we should move on then.
Okay, good afternoon everyone. My name is Lidia Casanueva. I'm pediatric intensivist at the Royal Brompton Hospital and also part-time consultant of the regional long-term ventilation service based at the Brompton. And next slide, please. I'm going to describe you a real case that was presented to our service some time ago now, that I think highlights very well the complexity and the relevance of having a structured support mechanism in place to serve difficult decision-making around initiation of respiratory technology. So the case was about a baby girl with antenatal care in an Eastern European country. It was a Polish family who was born in a district general hospital in the UK. She was born in poor condition and was intubated soon after birth for poor respiratory effort. And shortly after the admission to the neonatal intensive care, she developed clinical seizures that were very difficult to control with the usual anticonvulsant medications. On examination, the baby was very abnormal, she was very hypertonic and has continuous abnormal movement and very little interaction with her surroundings. Next, please. This baby was widely investigated by the team, but none of the investigation came conclusive for any specific diagnosis. They performed a brain MRI at day 4 of life, which was extremely abnormal with global hypomyelination, prominent spaces, absence corpus callosum, and a very flattened and thin pons. And at this point, she was transferred to a tertiary center for ongoing care. The baby continued to deteriorate further. The seizure activity was only partially controlled with medication, and she progressively developed ventriculomegaly on serial cranial ultrasounds and severe valvular dysfunction. The team tried to extubate her in several occasions, but they failed because the baby essentially was not breathing. Next, please. So members of the multidisciplinary team at the respective hospital, they collectively believed that the nature of the neurological condition was progressive and they couldn't offer a specific treatment to control or reverse the course, and they counseled the family for withdrawal of life support. But the parents disagree and wanted everything to be done, including tracheostomy and lung ventilation. And at this point, our service was contacted for a second opinion. Next, please. And the overall atmosphere when we first met the team was one of intense suffering and helplessness by both parts. On the left-hand side of the slide, you can see the views of the team. And I can say that although they were mainly on agreement of not to offer tracheostomy LTV, because it seemed like a baby with a progressive and severe cognitive and brain stem dysfunction, some members of the team felt a bit uneasy about the ethical obligation to provide LTV because they didn't have a specific diagnosis and hence they couldn't predict a specific prognosis, and also because they were in a relative early stage of the disease. There was also some controversy around offering a secure airway, a tracheostomy separated from LTV, in order to improve baby's comfort and prevent from accidental extubations. And also bed pressure was a factor that was raised by the team. It was a busy neonatal unit, and the baby was at this point beyond the neonatal period, and they want to transfer the baby to the pediatric intensive care with the decision already made. Then you can see the views from the parents. To give you a bit of background of this family, they were very dedicated parents, particularly the mother, who spent long time at the bedside holding the baby. They had very little social or family support. They had strong religious beliefs. They were a Catholic family. They understood well the medical information that was provided via interpreter, but argue about the lack of a specific diagnosis and they hope for a miracle. However, they understood as well that the baby had a serious brain problem and was unable to breathe by herself, but still wanted to care for her at home. And essentially, they felt confronted with the decision of LTV versus withdrawing life support treatment, or in other words, choosing between death and life, and they were not ready to accept this and wanted everything done, including tracheostomy. Next, please. So although I think this is quite extreme example, highlights well the complexity and the many factors that are playing in the decision making, which are unique for each individual family. If you see within these factors, under the umbrella of clinical considerations, we have to consider diagnosis, which, as in this case, may be unknown, the level of system support, so we may have single organ failure or multi-organ failure, the level of dependency, the cognitive ability to relate with others, and also the prognosis, including the predictability and the progression rate of the specific condition. Moving on to the umbrella for family consideration, it's essential that we consider family values, including cultural and religious values. Many of these families rely on their faith to keep going, and that's something that we cannot take away. Also, although it was not relevant in this case, the voice of the child is very important in some other cases. And it's important to understand the background of the family, what kind of support do they have, and what is the impact of the overall family life. So we met with the team. We never met with the family because we agree that in this particular case, offering tracheostomy LTV, really the burdens were much greater than the benefit. And we didn't want to raise any false expectations around what our team represented, which is home. So we met with the team and just offer like a space of reflection. Think for the team to reflect is to consider what are the goals of treatment and the alternatives, considering harms and benefit for each, and early consideration of parallel planning and shifting the focus towards comfort care and establishing ceilings of care. For the family also to consider these alternatives, which is pros and cons, and have a proper understanding that LTV is only an assistive technology for respiration, which doesn't really change the underlying condition or alleviate the burdens for the comorbidities. And to give you a hint of what was the outcome of the case, so the case ended up going to court, and the child further deteriorated while they were waiting for the resolution, which was against the parents' wishes. But at some point, the child was not interacting at all. She didn't respond to pain or had any respiratory drive or had any kind of contact, and were the parents themselves who approached the team and request withdrawal of life support before they were communicating of the final resolution.
Thank you. We've got a question, so not necessarily for Lydia. Shall we go to that, Kathy?
Yeah, sorry, just turn my mic on. Yeah, so, that's fine.
So Andres Almario, who's actually shares my office, but not here today, has asked, from the point of view of fairness of resource allocation, could the postcode lottery be seen as unethical? And I think clearly there's a difference between the way that care packages and other support is allocated across the region. I don't know, Kathy, do you want to answer that?
Yeah, I think absolutely would be my answer. It is unethical, isn't it, that we've got this inequity across the system, but we also know it's not just for children who need care packages, but in a way, that's what we're talking about now, and we know there's stark variation across the country. What I was talking about at the beginning was about the development of integrated, I still can't say it, integrated care systems. And all that means is where we have clinical commissioning groups at the moment that fund care packages in a borough, on an individual borough basis, they're being pulled together, so together with health and social care. So that's that link up of primary care, social care, so your housing allocation, for example, and health working together across a wider patch. So by default, you will get rid of some of the borough variation, but what you won't then get rid of is ICS variation. So you'll have bigger cohorts, maybe 7 or 8 boroughs coming together to form an integrated care system. And we envisage that would then standardise care packages across that system. But our aim, and we're obviously doing wider work on this, there's the LTV ethics group, but we've got various groups pulling together with the networks in particular, and charities and parents and commissioners working together to look at this as a system-wide. And what we're hoping to do in London region is to get this signed up, get the ICS leads to sign up to agreeing a standardised way of doing this across our region as a starting point. The bottom line, though, is the funding pot is the funding pot. So however they carve the cake, some benefit and some won't. So ultimately, this is about how important it is from and I'm getting political now, but it is about how important it is, how valued are children with complex needs, special needs, in terms of receiving the right budget that's required to deliver this. So in one way, you've got a political challenge, but we have got some opportunities to reduce the inequity and really work together with our CCG commissioners and our integrated care systems to try and improve this. Sorry, a bit of a long-winded answer, but it's complex, isn't it?
Kathy, Joe here. Might I jump in?
Yeah, please do. Please do. Should we show our faces? It feels really weird. I'm going to show my face.
I'd rather not show my face, actually. I just think the focus, again, there are two issues here, not one. One is equity of decision-making and access as in a right to have a treatment or to not have a treatment that might be harmful. The second is resource allocation. Now, they're very linked.
Yeah.
You see two issues here. One is a family, and let's say the same clinical situation, a child who it's a very straightforward, everyone would agree to support that child in that situation with tracking LTV for, I don't know, whatever indications. But then the difference in the provision of nursing care in different regions, and I pushing further, you're talking about different boroughs in one city. Surely we should be thinking about different cities, different regions, country versus town, all that kind of stuff. I'm going to get even worse now. So it's almost like broadband, isn't it? It's a lot harder to supply the further you are from a major city, I suspect. I mean, there are people in here that understand this much more than I do. But I suspect that's the case, or am I completely wrong? So where you live is hugely important in this, not just in deciding who gets LTV, but how much they're supported once it's decided they will get LTV.
I think your broadband might be fading, Joe. Actually, you're sounding a bit distant. Actually,
that's good. Well, clearly, I'm broadbanded away. Did my point make sense? Did you hear enough of that?
Yeah.
Definitely. Yeah.
More than enough.
Okay, we've got another. Should we move on? So I got another question here. So. This is from Leeds. Christopher Edwards said, currently involved in a very similar case. Is there a chance of some sort of database of cases to help inform decisions nationally? So I think that's certainly we're looking at a database of children with long-term ventilation and tying into that, looking at how we can incorporate the sort of ethical component to those decisions in that process, so that we can see firstly how one thing is how the framework helps and works, and to make sure that we're getting the right things. But yeah, I think that would be something that we would be looking to do. If that answers that. And then coming down, Grace Williamson from Newcastle upon Tyne, interested to hear about the Pan-London Bioethical Support Group. I'd heard there were plans to set up a similar group under the aegis of PICS PCCS. Is that still going ahead? Joe, do you want to take that? Or has the broadband gone completely?
Might have lost him. Let me just see.
No, you haven't. I was busy typing the answer. I was busy typing the answer to the next question badly. To about the database. What was this question?
So this is about, so it's Grace Williamson from Newcastle has asked, interested to hear about the Pan-London Bioethical Support Group.
Yeah.
I'd heard there was possibly one coming under PICS PCCS. Is that still going ahead?
The PICS one, the PICS one we tried to establish and set up early in COVID at a time when we thought we might be overwhelmed with large numbers of children. So that was kind of James Fraser and I talked about we were going to set something up. But actually it became readily apparent that for COVID, particularly, we probably didn't need that. It's not to say it isn't a good idea, we should think about it anyway. One of the issues with it, though, is a national setup is really hard without funding and everything. So a more regional thing, which we set up actually in terms of London for this. We drove it a bit with COVID, having set things up initially with LTV. Is something we should think about. There's lots of governance aspects. I'm happy to share them with you in terms of what we've discussed in that Pan-London group. But so it's progressed a bit during COVID regionally, and I would certainly think it's a good idea to think about doing that in your region. Our original plans for a national bioethics support group years ago were that hub and spoke, if that makes sense. And the PICs would be a natural place for that, because people already send children into certain centres for PIC services readily, and so it is something we had talked about and planned to try and get funding for, but it was very hard.
I think it might be Ruchi's turn.
Hello, hi. I'm Ruchi Sinha. I'm one of the PICU consultants at St Mary's Hospital, and I've been working with the group to develop a formal consent process for establishing long-term ventilation. I think from everything that we've seen so far, we can see that it's really important that the family have a clear understanding of what LTV is, what it means for their family, and what the main aim for going down this process for their child is. I think once you've got the proper understanding for the child's condition and the clinical course is established, and that's through the multidisciplinary team in the context of the framework that Richard showed you earlier, then we can move on to formal consent. And the principles that underpin any valid consent process are well established with the GMC and the Department of Health, but really it's all about getting an agreement with the medical teams and their family or patient about a decision for that patient without coercion, and that agreement has to be based on a good understanding of all the relevant information in order to make a rational decision. So I think it's the next slide actually. Thank you. So why should we do this? I think it's important for many reasons, but if you think about it, with some children, I think establishing long-term ventilation is actually not that dissimilar to submitting a child to organ transplant. And yet you wouldn't put someone through a transplant without making sure that the parents truly understood what they were signing up to. You know, what's the diagnosis, what's the purpose, the process, the procedure, the complications, and the long-term fallout. And I think it should be the same for long-term ventilation. And actually, we've learned from the experience of some families that have gone on this journey that actually their expectations were not quite realised, or what they thought was going to happen, they didn't feel was clearly relayed at the outset. And that's led to long-term management and ethical and legal challenges. So I think you can see from Lydia's presentation in particular that the impact on the whole decision-making process and the quality of life, a consent process might help to clarify what we're doing and why we're doing it. And it sort of fits in with the operational framework. And it also provides an opportunity to develop some parallel planning, because if you're not going to go down an LTV route, it might be that you have to go to a palliative care, a redirection of care, and think about conversations with advanced care planning. And I think it's important to realise that this isn't a one-stop shop, and that actually there should be revisitations of this process, so there's always points at which they can exit this pathway. Next slide, please. Thanks. So it was difficult to decide what we needed to put in it. There just seemed like you wanted to put everything in it. But I think importantly, we really should focus on the treatment intention. So why are we doing this? What's the purpose of this? Is it a bridge to recovery, or is it a long-term destination? What are the expected outcomes in the short, medium and long term? And again, these should be revisited because things might change. How long is the treatment? Is it forever? Are there any other procedures? But again, I think what's very important is that we're clear about exit strategies and palliative care input and parallel planning, so that we know that parents can change their mind, or the situation might change. Next slide, please. So to provide this information, I think the parents need to have a good understanding of what it is, really understand what they're getting into. So it would be ideal to have a trained team, a multidisciplinary team who have resources to help parents get to this point, using videos, recorded information, leaflets and booklets, and websites like the one that, that Richard mentioned previously, like the one that I've got on here, Family Reflections. And we should focus on additional procedures. Also, what was expected of the families. I don't know, we always talk about the competency of families and other caregivers, what they need to be able to achieve to get their child home, if indeed they will get to the same home, and how long that whole thing will take. So I think identifying key members to train and perform consent is really important to this process. Next slide, please. So the first thing is really about understanding the underlying disease and the progression, and whether this is a bridge to recovery or whether it's a permanent state. Next slide, please. The goals should really think about why we are doing this. So the first part of consent is understanding the condition of the child and the progression, and then why are we doing this? So for example, are we putting them on long-term ventilation to treat hyperventilation, or is it a child that's got end-stage respiratory failure and this is to help the family deliver end-of-life care at home? What is the end point? What are the agreed goals? Next slide, please. there's lots of risks and burdens, and we've listed here some of the things that we may want to touch upon. And you can see that this is going to be a long process and probably need multiple meetings and to go through this and again. And it'll range from things like the actual tracheostomy itself, dealing with a complex technology at home, changing the nature of family life, all the things that are listed here. But I think the final point is the one that we really should focus on as well, and not forget that there is an option not to pursue chronic mechanical ventilation, and that actually there is parallel planning that should be in place as well. Next slide, please. Next slide. Mine's stuck as it moves on to the next slide. Yeah, thank you. In all of this, we really have to also remember the immediate child in front of us. So we do need a technical consent as well. So things like involving the ENT team and tracheostomy nurses about placement of the tracheostomy, and also the complications of trying to establish LTV. And part of this shouldn't just be about what is physically going to happen, but also where is it going to be happening? How long are they going to be on PICU? How long on the ward? Which hospital? Which ward? And what the training expectations are during this time for caregivers. Next slide, please. So, as I said, this fits in nicely with the framework, and I think it gives the opportunity to really bring parallel planning to the fore. And there should be, clear points of exit all along the pathway, because things may well change. And also, we should consider advanced care planning as part of all of this and ceilings of treatment. Next slide, please. So this is just who we think should be involved in the process. So that's the respiratory team or the long-term ventilation multidisciplinary team, the referring or the overarching clinicians. So that could be paediatricians or neonatologists or neurologists, any other specialists if the child's got additional medical conditions, the surgeons or the tracheostomy team, palliative care team, social workers and psychologists. And I think, it's important to have clear guidance on how to do the consent, because establishing those goals at the beginning, I think, is the key to the whole process once you get to this point. Thanks. I think that's me. Yeah. Thank you.
Ruchi, thank you. We've got another question here from Andres or Mario. You mentioned parallel planning of palliative care. Are we required to disclose this parallel plan to the family, and at what point do you usually involve palliative care?
I think in an ideal world, it is good to involve palliative care at the start, because I know that there's a great burden on palliative care within the London setting, that it was difficult to get involved with every single child that's going to be on LTV that is on LTV. But when we discussed this at a national meeting, I think other teams felt that you couldn't really embark on the LTV journey without having parallel planning in place, because if you don't go down an LTV route, and certainly if you're taking consent, what is the alternative? I think you do need palliative care from the outset.
There may be some condition-specific times, given the resource limitations of palliative care. So I think potentially there are some children where it's more of a notification.
I agree with Ruchi totally, because I think some conversations is better that happens in an early stage, away from acute and uncontrolled circumstances when it's very difficult to approach families. So I think the earlier we introduce parallel planning in children with life-limiting condition, I think the better. Yeah, thank you. So I'm going to present you this case that this infant was in our hospital for many, many months, and it was a very complex discharge, and I'm sure you may all have similar cases like this one. So the background of this baby was trisomy 21. He has complete AVSD and chronic lung disease in the context of recurrent pulmonary aspiration. He also had pulmonary hypertension and other comorbidities like imperforated anus, congenital hypothyroidism, etc. He was extremely dependent on non-invasive ventilation. We were unable to take him off the mask. And the first hemodynamic study for his congenital heart disease was unfavorable for repair. And he was finally referred for LTV at 8 months of age for tracheostomy and long-term ventilation. Next, please. So tracheostomy was inserted when he was 9 months old of age. Then the cardiac catheterization was repeated with better hemodynamics. So the heart condition was repaired successfully. He went onto portable ventilator at 10 months of age, and a PEG-J was inserted when he was 1 year old, and then he was transferred to District General Hospital at 1 year of age. He was considered first fit for discharge from hospital at 143 days, but the overall length of stay was over 400 days. Next, please. So you can see the roadmap on the right-hand side, many steps that needs to be completed before these patients can be discharged home. And in this case, coexisted many challenges. The first one was housing, which is cornerstone in the overall path. Their house was considered unsuitable, and it took 1 year to find a 3-bedroom property. Also, they were immigrants. The father was a Palestinian refugee, and he had a health problem, so was considered to be untrainable and unable to look after the baby. So in this case, the mother was assumed to be a single parent, but they also had another sibling. Next, please. There were also some issues about initiating and establishing the care package, the problems with different care agencies. And also it was a lot of pushback from the community team because the patient continued to acquire respiratory exacerbation, getting unwell, and it was a lot of anxiety from the community team to have them under their care, to have him under their care. And my last slide, please. Yeah, so I think that's a clear example on how difficult and how complex is the overall path for these children before they can be discharged home. No question, we are getting more and more often patients with greater complexity who also live longer. And the question is, what can we learn from them and how can we serve them better? So they are a heterogeneous population who usually have multi-system problems and are fully dependent on technology. And the overall characteristics make it quite difficult to predict outcomes. As we've seen, they also have a lot of challenges around decision making and specific ethical consideration. So we need a different care paradigm for them. It's important to acknowledge the individual clinical trajectory of these patients and their families, acknowledge as well the parental role and engage all the care providers early, and as we discussed, to have early involvement on palliative care team or parallel planning. And last but not least, an effective and compassionate communication with these families that are facing great suffering is essential. Thank you.
Just to go through the next steps, the bits we probably haven't quite covered for everybody just yet. The entire process is not to be a decision-making just to commence LTV. It's very, very important. A regular review, annual with the respiratory team of the ethical decision-making that has gone on, see how things have changed. So many times a decision may be made to go on LTV that may be the right decision initially and may no longer be the right decision. So having that ongoing meeting with the child and family regularly to assess what's going on is important. The second thing with the initial team was going to be fully multidisciplinary. We haven't mentioned lots of colleagues that are on the document. So neurologists, occupational therapists, physios, I will miss somebody out that's very crucial. But we really wanted this to be everyone who could be involved with that child's journey. The next steps are going to be to try and get the database establish somehow, try and get information about whether this pathway is useful. To ask you guys what you think about what we've shown up to now. Maybe the people who are on the today, there have been a couple of faster slides to be circulated, which I'm sure we can do, but also we can send the pathway to date to you for comments and thoughts about the stuff that we've done. That's kind of where I was going to finish. Anything from anybody else?
I think you've highlighted the key points there, Joe, in terms of we need feedback, we need people to see the pathways, and exactly, we can send the actual documents out to people to comment on. The aim of this is for it not just to be a London region and southeast piece of work, it's something we want to get across the country and to emulate and replicate, but to get it right. So we'd really appreciate everybody's feedback, and particularly around the database. We've equally been trying to work, I think it was, is it Brier, I probably said your name wrong, mentioned earlier about contacting ICNARC and PICANET in terms of looking at getting a database. We've certainly been doing
it's all been done. Yeah.
Yeah, exactly.
Brier is me, it's my other sign-in.
Oh no! That's hilarious.
I was just saying people who have contacted ICNARC and PICANET. That's
who's this Brier?
Together is a bit difficult.
Well, there you go. I thought, we had a partner in crime there, Joe. I thought we'll have to nab that Brier. But yeah, obviously we all acknowledge that data and really seeing if this makes an impact is going to be important as well, isn't it, in terms of how we monitor stuff going forwards. But yeah, just to echo, we need people's feedback. That's all I was going to add. It's pretty much saying the same thing, wasn't it?
I think we're over time, and there's nothing as bad as a lingering webinar. So if there are no other comments, I'm going to close things, okay?
That's fine.
Thank you all.
Thank you, everybody. And yeah, we'll be in touch with some information and slides for you all.